Hello, I'm Ruth Ross. In this lecture, we are going to discuss drugs that interact with an important group of enzymes called the receptor tyrosine kinases. In this lecture, we will first discuss the role of ERBB receptors in cancer and then talk about the drugs that interact with the ERBB receptors that are used in the treatment of various types of cancer. We will then have a brief description of the two major forms of diabetes and introduce you to the discovery of insulin and to its use in the treatment of diabetes. Finally, we will discuss treatments with anti-hyperglycemic agents which are used to treat type 2 diabetes. In our previous lecture, in which we outlined the role of ERBB receptors and the growth factors that activate these receptor tyrosine kinases, we outlined the signaling systems that are activated in the cells and showed you how these lead to increased cell proliferation. We also talked about how important these receptors are in normal cellular growth, particularly during fetal and child development, when large amounts of cellular growth are required. Cancer is a complex process. However, we know that malignant transformation of cells involves inappropriate or unregulated cellular proliferation. Transformation arises from a number of different mechanisms, many of which are still not very well understood. Exposure to a variety of environmental factors that can introduce mutations into cellular DNA or inhibit the ability of cells to repair mutations in DNA are some of the factors involved in malignancy. If these mutations arise in pathways that regulate cellular proliferation and survival, this can lead to the formation of tumours. There are several proteins in the ERBB pathway that are known to be mutated in a number of different human cancers. As shown here in this slide, mutations can occur in the ERBB receptors, such as ones found in the ERB2 mutations. When ERBB2 is mutated, it is known as HER2. HER2 mutations found in many breast tumours result in receptors that are active in the absence of ligand. And we call this constitutive activity. When this occurs, the receptors signal to the downstream pathways, such as the GRB2, SCH, SOS pathway, that is involved in activating RAS and MAP kinases, resulting in an increased cell growth. Another type of mutation that is common in many types of cancers is the mutation in the RAS protein. These mutations result in RAS being active for a longer time than normal RAS proteins, so that signals through the ERBB receptors will last much longer than normal and result in a prolonged stimulation of cellular growth. There are a number of cancer types that have ERBB mutations. HER2 mutations are found in many types of breast cancer as well as some cancers of the gastrointestinal system. ERBB1 receptors are also dysregulated in some types of cancer, such as colorectal cancers and non-small cell lung cancers. Therapeutic approaches for tumour treatment typically involve first-line treatments such as surgical removal of the tumours, radiation therapy before and after tumour removal, and also chemotherapy. Many chemotherapy drugs are cytotoxic agents which inhibit cellular replication by their effects on DNA synthesis and repair. These agents are relatively non-selective, having the greatest effects on rapidly dividing cells, such as those found in tumours. Drugs that target ERBB receptors and signalling systems are more selectively targeted to tumours that are known to express mutations in these proteins. These agents are often used in addition to or following more broad-spectrum, less selective chemotherapy, in which they are called adjuvant therapies. Drugs that bind to and inhibit ERBB receptors can be divided into two groups. The first are the drugs that are called antibodies, raised against specific parts of ERBB receptors, hence they are known as monoclonal antibodies. These drugs are directed to the part of the ERBB receptor that is on the outside of the cell, where the ligand binding domains are. These include drugs directed to ERBB2, HER2, such as Herceptin, which is a monoclonal antibody made by the company Genentech. Herceptin has been used for many years in the treatment of HER2-positive breast cancers, in other words, breast cancers expressing this particular receptor. It is also being tested for the treatment of some types of gastric cancer that are also HER2-positive. Another drug that fits into this category is cetuximab, a monoclonal antibody developed by Bristol Myers Squibb and Eli Lilly and used in the treatment of head and neck tumours as well as metastatic colorectal tumours. These tumours express large amounts of ERBB1 receptors that respond to growth factors such as EGF through the Ras/MAP kinase pathways. The second type of drug used to inhibit ERBB receptors are small molecules rather than antibodies, and they can cross the cell membrane to bind to the inside of the tyrosine kinase domains of ERBB1 and ERBB2. These include the compounds that are shown here, which have been developed by AstraZeneca and Genentech. And these are used in the treatment of non-small cell lung cancers, which are slow-growing tumours that make up the majority of lung cancers. But given that lung cancer represents about a third of all cancer deaths, for example, in Canada, drugs to treat these cancers are a very important class of drugs. Also listed on this slide are several small molecule inhibitors that inhibit both ERBB1 and ERBB2. And these are also used primarily to treat non-small cell lung cancers. So let's take a closer look at two of these drugs. First, we will look at Herceptin. This monoclonal antibody has been jointly developed by academic and commercial labs of the Johnson Cancer Center at the University of California in Los Angeles and a company called Genentech. It was first approved for use 15 years ago after clinical trials which showed that 42% of patients taking Herceptin in combination with cytotoxic chemotherapy had a positive response, a positive survival outcome, compared to 15% of patients taking chemotherapy alone. Treatment with Herceptin is very expensive, costing between 35,000 and 45,000 Canadian dollars per year. For one patient. It took considerable lobbying of the government on the part of patients to get coverage of this drug under the provincial healthcare programs in Canada, but its use is now covered in most provinces in Canada. In the figure shown on this slide, you can see what's called the crystal structure of Herceptin, shown in blue, and in yellow, the extracellular domain of the ERBB2 receptor, shown in pink. As you can see, the antibody is a very large molecule, and when it's bound to the ERBB2 extracellular domain, it changes the conformation of this receptor. Remember that the ERBB2 receptor is thought to have activity in the absence of ligands, or the absence of compounds. And it's a very potent activator of cell proliferation. When it heterodimerizes with other ERBB partners, because of its ability to stay on the cell surface for longer times than other ERBB receptors. Binding of Herceptin to the outside of HER2, or this receptor, inactivates the protein and significantly decreases the proliferation of cells which express this particular HER2 receptor. In this slide, we see the structures of two of the small molecule inhibitors of ERBB1. As you can see, these are much smaller than the antibody we saw in the previous slide. These molecules are hydrophobic enough to cross the cell membrane and bind with high affinity to the receptor tyrosine kinase domain of ERBB1. The crystal structure of this domain is shown on the right of the slide, with one of these drugs bound in the active site. Also shown in the crystal structure are 3 amino acids, a glycine and 2 leucines. In the ERBB1, they are commonly mutated in non-small cell lung cancers, and these mutations confer increased activity to the mutated ERBB1 receptors. So the binding of these compounds inhibit the receptor tyrosine kinase activity, inhibiting its ability to stimulate its partner proteins and thus inhibiting signaling of this receptor. Diabetes mellitus is a group of metabolic disorders related to the body's ability to utilize and store energy, particularly from glucose. Diabetes is a highly prevalent group of disorders which has an estimated worldwide prevalence of 285 million cases currently and rising every year by about 7 million more. The 2 major forms of diabetes are type 1 diabetes that accounts for approximately 10% of diabetic cases. In type 1 diabetes, the pancreas makes insufficient amounts of insulin, and the patient must receive exogenous insulin therapy. Type 2 diabetes is the most common form, accounting for about 90% of diabetic cases. In this condition, the body becomes resistant to the effects of insulin. It is this type of diabetes that is increasing at alarming rates around the world. The 2 other types of diabetes are diabetes insipidus, that is a very distinct condition related to the hormone vasopressin and not insulin. Finally, there is a type of diabetes found in 2 to 4% of pregnant women called gestational diabetes. Women with this condition are at a higher risk of developing type 2 diabetes in later life. Diabetes is associated with a group of symptoms that include excessive thirst and excessive urination. It is also accompanied by sudden changes in body weight. However, diagnosis of diabetes is usually made by a combination of blood tests. The first indications of diabetes come from glucose levels in a fasted plasma sample. Following an overnight fast, normal plasma glucose levels are less than 5.4 millimoles per litre. People who have plasma glucose levels higher than 6.9 millimoles per litre are considered to have diabetes, while those who have levels between 5.5 and 6.9 are considered to be pre-diabetic and at high risk for diabetes. Typically, people with high fasting plasma glucose levels can be tested for glucose tolerance, in which the patient is given a meal or beverage containing 75 grams of glucose, and then their plasma glucose is measured again after 2 hours. If the result from the second blood test is between 7.7 and 11 millimoles per litre, they are said to have impaired glucose handling. Levels above 11 millimoles per litre are seen in people who have overt diabetes. People with increased fasting plasma glucose or glucose tolerance may have either type 1 or type 2 diabetes. Diabetes has been known for centuries. In fact, descriptions of the symptoms of diabetes have been found from ancient Egypt 3,500 years ago. However, it took until the early 1900s before progress was made to find the hormone that actually regulated glucose uptake, utilization and storage. And that hormone is insulin. In 1889, Oliver Minskowski and Joseph von Mering of the University of Strasbourg, France, demonstrated that removal of a dog's pancreas resulted in diabetes. But it took until the 1920s for 4 scientists working here at the University of Toronto to isolate an extract of pancreas and treat the first patient with insulin. Those scientists were Frederick Banting and his assistant Charles Best, a medical student, working with Dr. James Collip under the leadership of John MacLeod. Banting and Best isolated an extract from fetal bovine pancreas and used it to treat dogs that had their pancreas removed. Collip joined Banting and Best and helped refine the isolation of the active ingredient from the pancreas. In 1922, the first patient to be treated with the extract was a 14-year-old called Leonard Thompson. As you can see from the picture of Leonard before his treatment, his body was very small and emaciated. 2 months later, after treatment with the pancreatic extract, he gained weight and is looking much healthier. Leonard went on to live for another 13 years before dying of pneumonia. The word insulin was first used in 1922 to describe the active hormone in the pancreatic extract. Banting and MacLeod went on to receive the Nobel Prize in Physiology and Medicine in 1923 for their role in the discovery of insulin. Banting shared his prize with Best and MacLeod shared his with Collip. The University of Toronto entered an agreement with Eli Lilly to mass-produce insulin, and it became available for the treatment of patients with type 1 diabetes in 1923. The discovery of insulin is still considered to be one of the greatest achievements of the University of Toronto and in fact of science in general, and there are several buildings at the University of Toronto that bear the names of Banting, Best and MacLeod. So if we examine the typical symptoms of the lack of insulin that are observed in diabetes, we see that the effects of this disease go beyond lack of glucose tolerance. Patients experience hyperglycemia that results from both underutilization of glucose and excess production of glucose from the liver. Excess glucose in the blood has an osmotic effect, resulting in the body attempting to resolve plasma hyperosmolarity by taking in water. Polydipsia, resulting in constant thirst. As the body attempts to excrete excess glucose in the urine, resulting in excess urine production known as polyuria. The patient experiences excessive weight loss, muscle and tissue wasting from the inability to utilize energy from glucose. The body then attempts to compensate for this lack of glucose energy by utilizing fatty acids for energy, increasing lipolysis. And production of ketone bodies from lipids can lead to increased acidification known as ketoacidosis. Lipid metabolism is also abnormal in diabetes, resulting in increased lipolysis with increased plasma triglycerides and low-density lipoproteins, also known as LDL, and low levels of high-density lipoproteins or HDL. Together, these metabolic changes result in increased heart disease. Emergency medical treatment is required when diabetics are severely hypoglycemic, resulting in diabetic ketoacidosis as the body attempts to utilize fats for energy. This condition will result in coma and eventual death if not treated with insulin. Less urgent but chronic conditions that result from poorly treated diabetes arise from poor glycemic control. Over time, this leads to a series of complications in the nervous system with loss of sensory nerve function. Chronically poor cardiovascular health results in microangiopathies, resulting in damage to the retina, kidneys, and limbs. Diabetic retinopathy is one of the leading causes of blindness, and kidney disease associated with diabetic complications is one of the leading causes of requirement for dialysis. Ischemia is the lack of sufficient oxygen supply to the tissues, and this is common in diabetes, particularly in the feet. People with diabetes have to be very careful in the treatment of any injuries to their feet, as they tend not to heal well. Macroangiopathy results in increased atherosclerosis in diabetics, with concomitant increased risk of cardiovascular death in type 1 diabetes compared to non-diabetics. This is particularly high in females who have a 7 times higher risk of cardiovascular death than those without diabetes. The goal of modern insulin therapy is to mimic the normal bodily control of plasma glucose. Shown in this graph here on this slide is blood glucose levels over the course of 24 hours in people without diabetes, and it's seen in the lower purple line compared to those with diabetes shown in the upper black line. As you can see, glucose levels do not vary a lot over the course of the day and night in a non-diabetic. But you can see that in the non-diabetic, they respond to food intake with a rise in blood glucose levels that rapidly match with the insulin secretion that increases glucose uptake into the liver and muscle stores, maintaining blood glucose levels with a fairly narrow range. For the diabetic, on the other hand, the intake of food means a large spike in blood glucose that have to be controlled by insulin injected, that is able then to restore blood glucose levels to the normal range over time. You can see that for the diabetic, a considerable amount of the day and night are spent with blood glucose levels that are well above the normal range. In 1936, Hans Christian Hagendorn, founder of Novo Nordisk, discovered that adding protamine to insulin significantly prolonged the duration of its action. Insulin is rather poorly soluble and associates into hexamers that must dissociate into dimers and monomers before it can be utilised. The rate-limiting step for absorption of insulin from its site of injection is its dissociation into dimers. Different formulations of insulin dissociate at different rates, thus delivering insulin over different time frames. In this slide, you can see the different formulations of insulin available for treatment. These range from ultra-fast-acting Lispro insulin that has its peak action 30 to 60 minutes after injection, to ultra-long-lasting forms of insulin that are slowly released over 24 hours. The goal is using these various preparations is to allow the patient to control their blood glucose levels over the day and night with different levels of incoming glucose from food or release of glucose from the liver. Let's look at a conventional insulin therapy regime over 24 hours. The patient injects the long-acting Lente insulin twice a day to give a low level of insulin shown here in blue. The patient injects a regular insulin in the morning before breakfast and then again in the evening before supper, shown in pink. The combined insulin levels are shown here in red. The regular insulin helps utilise the glucose from breakfast, while the slower acting Lente insulin helps to deal with the glucose from lunch. The glucose coming from supper and evening snack are controlled by the evening regular insulin, and the slower Lente insulin maintains glucose levels overnight. This regimen minimises the number of injections every day. However, it does not give very good glycemic control. In the early 1900s, the made available. So what was involved with this intense therapy was the patients monitoring their blood glucose levels many times over the course of the day and adjusting the dose of the insulins they took to match the insulin doses more closely for their blood glucose levels and their food intake. This requires a significant daily commitment from the patients to monitor and adjust their medications and typically increase the number of injections of insulin that were required. Thus, if we compare the previous regimen with 2 injections from regular Lente insulin each day with the new medication regime, which would look more like we see here in the bottom graph, in which patients inject the very short-acting Lispro insulin before each meal 3 times a day, with a long-acting insulin included once a day to give a low background level of insulin overnight. Alternative methods of insulin delivery have been developed in the form of a pump, which is attached to a catheter in the patient. The pump allows for continuous infusions as well as patient-initiated doses of short-acting insulin before meals. In this example here, the pump delivers a basal infusion of Lispro or regular insulin to control hyperglycemia overnight. And the patient triggers infusion of the same insulin before meals. The advantage of the pump is that the patient does not have to inject themselves several times a day, and the low background levels of insulin can be delivered more constantly by infusion. When insulin is injected or delivered by a pump, the standard method of injection is subcutaneous or under the skin. Intradermal administration under the skin results in poor absorption, whereas intramuscular injection would result in accelerated absorption. Other things that regulate the rate of absorption of injected insulin are the rate of blood flow through the injection site and the site of injection, with absorption from the abdomen or buttock being faster than from the thigh or deltoid area. Ambient temperature will also affect insulin absorption rates, so that higher body temperature will speed up the absorption rate. Finally, exercise will also increase the rate of absorption, as it both increases body temperature and blood flow to the site of injection. The greatest problem that the diabetic patient experiences with insulin treatment is the risk of hypoglycemia. Because type 1 diabetics are dependent on insulin, they have the greatest risk of experiencing hypoglycemia because of inappropriate matching of insulin for food intake. Mild hypoglycemia can be dealt with using rapid sources of glucose from juice or glucose tablets. More profound decreases in glucose level must be treated with glucagon injection to rapidly increase glucose release from liver stores. Other issues that arise are allergic reactions to insulin. And these were more common in the past when insulin was prepared from pig pancreas, which is very similar to human insulin. However, there are a few amino acids that are different, and in some patients, this resulted in immune responses. Now, human recombinant insulin is used, and these reactions are seen far less. Other less serious complications include local areas of lipohypertrophy around the sites of insulin injections. These are increased areas of increased fatty tissue, and they can cause unpredictable absorption, but they can be avoided by moving injection sites regularly. Finally, lipoatrophy or loss of fat can occur at injection sites as a result of impurities in insulin preparations, but these are again uncommon with more modern preparations. So let's talk now about the type of diabetes that is far more prevalent, which is called type 2 diabetes. The symptoms of type 2 diabetes are far less obvious than those observed with type 1 diabetes. And type 2 diabetes is slow onset disease. Type 2 diabetes results from resistance to the actions of insulin, but may later develop into loss of insulin as well. It is a typical onset later in life, usually after the age of 40, and it is polygenic disease, meaning that there's no single cause of type 2 diabetes, and it is a progressive condition. As the disease progresses, 20 to 30% of patients will become insulin dependent. However, type 2 diabetes is also treated with a wide group of drugs. As seen from the graph on the right, type 2 diabetes accounts for 90% of all diabetes cases. The statistics on the left illustrate how common this disease has become, and the percentage of people with type 2 diabetes increases every year in many countries around the world. The cost of this condition to the medical systems are extremely high and continue to escalate yearly. In Canada, for example, the annual cost of diabetes is estimated to be $13 billion. A considerable portion of the $207 billion total healthcare costs in Canada in 2012. The largest risk factor for type 2 diabetes is increased body weight. On this slide, we can remind you of how we categorise body weights in Canada, for example. The Body Mass Index, or BMI, is calculated from your weight in kilograms divided by your height in meters squared. People with BMIs in the range of 18.5 to 24.9 are considered optimal for good health, while those with BMIs over 25 are considered overweight. A BMI over 30 is considered obese, and over 40 is morbidly obese. In populations such as ours in North America, the percentage of the population that is in the overweight and obese category is increasing every year. In some populations, this classification of BMI does not fit well with the incidence of diabetes because people in some racial groups tend to gain weight around their stomachs but less over the rest of their body. For these groups, such as Southeast Asian populations, it has been suggested that measuring the hip to waist ratio is in fact more appropriate. For this measure, males should have ratios of less than 1 and females less than 0.9. Ratios higher than these are indicative of central obesity that is associated with an increased risk of type 2 diabetes. The graphs in these slides illustrate the increasing risk for diabetes as BMI increases. You can see that once a person has a BMI in the obese range above 30, their risk of diabetes increases dramatically. Typically, people gain weight as they reach later years of adulthood when their lifestyles often become more sedentary. In the graph on the right, it can be seen that any increase in weight in adulthood is associated with an increase in the risk of diabetes. The larger the increase in weight, the higher the risk. Thus, a person who gains 10 kilograms in weight will have 5 times higher risk of type 2 diabetes than a person who does not gain weight. This slide lists the pathophysiological hallmarks of type 2 diabetes. This condition is marked by insulin resistance rather than lack of insulin, at least in the early stages. Insulin resistance in target tissues such as muscle can be seen as a decreased number of insulin receptors, decreased insulin receptor kinase activity, and downstream signaling responses such as GLUT4 translocation. Effects on pancreas can be seen with impaired islet function, seen by loss of first phase insulin secretion, and that is the release of pre-stored insulin. There is also aberrant release of proinsulin into the circulation and defective pulsatile insulin secretion. In the islets, there is evidence of damage seen with advanced type 2 diabetes with deposition of islet amyloid polypeptide. Overall, it can be seen there are changes in multiple levels of type 2 diabetes. The first-line treatment upon diagnosis of pre-diabetic stage or overt type 2 diabetes are changes in the lifestyle. In particular, changes in diet and exercise are recommended as about 80% of type 2 diabetics are overweight or obese. These changes include decreased calorie intake, reduced fat intake, and increased physical exercise to alter the energy balance in the patient. Decreasing caloric intake is the major route to help people lose weight, and increased exercise important to increase glucose utilization by the body. Recent clinical trials have shown that exercising at least 30 minutes a day reduces the risk of type 2 diabetes more effectively, in fact, than medication. Regardless of the treatment, exercise improves glycemic control in all type 2 diabetic patients. Treatment of type 2 diabetes with drugs is often required and involves either a single or multiple oral hypoglycemic agent. Typically, it is a condition that progresses the number of medications needed for good glycemic control increases. With progression, 20 to 30% of patients will require insulin in addition to other drugs to control diabetes. Drugs that are used to treat type 2 diabetes fall into several categories. The first are the drugs that increase insulin secretion, and these are drugs such as older sulfonylureas and the newer glitinidides. The second group of drugs increases the tissue responses to insulin so that they are known as insulin sensitizing drugs that include these drugs shown here on the slide. These drugs also include metformin, one of the most commonly prescribed drugs for diabetes. The third group of drugs are inhibitors of carbohydrate or fat absorption from the GI system. And these include, for example, orlistat. In the next few slides, we will briefly discuss the mechanisms of action of each of these three groups of drugs. So this slide illustrates the mechanism of action of the sulfonylureas. As you will recall from the previous lecture on receptor tyrosine kinases, insulin is secreted in response to glucose uptake in the pancreatic beta cells, leading to elevation in ATP levels that inhibit the potassium channels in the cell membrane. Sulfonylureas bind to these potassium channels on the surface of the pancreatic beta cells. This causes them to close and depolarize the cell membrane. The resulting increase in calcium influx to the cell leads to insulin release from the storage granules. The example drug here is glyburide, which is a second-generation sulfonylurea that has less side effects than the first-generation drugs in this group. The major side effect of this drug and other second-generation sulfonylureas is the potential to cause hypoglycemia as a result of too much insulin secretion. Other drugs that also act by increasing insulin secretion are shown here on this slide. These drugs are amino acid derivatives with mechanisms of action that are similar to the sulfonylureas. Advantages of these newer drugs are that they can act very rapidly and may be more specific for beta cell potassium channels than other types of channels, and their actions are more glucose dependent. These drugs are taken with meals and they elicit a more rapid insulin release that is brief compared to the effect seen with sulfonylureas. Because they have a rapid onset of action after a meal, hypoglycemia is therefore avoided. Because their actions are brief, there is reduced risk of long-lasting hypoglycemia with these drugs than would be observed with sulfonylureas. The next group of drugs used in the treatment of type 2 diabetes are those that increase insulin sensitivity of tissues to insulin. Because insulin insensitivity is the primary problem in type 2 diabetes, this makes sense to use this approach. An example drug in this group is metformin, one of the mainstays of diabetic therapy. This class of compounds decrease fasting blood glucose levels, which are elevated in type 2 diabetes. The primary source of glucose between meals is from stores in the liver. These drugs inhibit the generation of hepatic glucose and its release into the blood. They inhibit glucose 6-phosphatase, which is the enzyme that releases glucose from glycogen stores in the liver and muscle. So they are considered to be what's called glycogen sparing. In the presence of this class of drugs, the insulin effects on glucose uptake are also increased, hence the reason they are called insulin sensitizers. One of the major advantages of this group of compounds is that they do not produce hypoglycemia even at higher doses, and so they are safer, particularly for use in the elderly, than the sulfonylureas. The other group of drugs that can be classified as insulin sensitizers are the glitazones. This group of drugs helps to deal with the need to store excess energy from food when there's insufficient need for that energy from exercise. The long-term effects of diabetes are thought to arise in part from the inability to store this excess energy in the form of fat. The glitazones act to stimulate a transcription factor known as PPAR gamma, which stands for peroxisome proliferator activated receptor gamma. This is a transcription factor, and it's key protein in the differentiation of adipocytes, which are white fat cells of the body. When patients take glitazones, they increase the amount of fat cells in their body and thus increase the potential to store energy in the form of fat. One of the problems with these drugs, as you can imagine, is that patients will tend to increase their body weight. Nevertheless, these drugs decrease the long-term effects of diabetes. The final group of drugs used to treat diabetes are those that inhibit carbohydrate and fat uptake from the GI system. Acerabose inhibits metabolism to glucose in the intestines, thus delaying the release of glucose from food and slowing delivery of glucose into the blood after a meal. This drug is a competitive and reversible inhibitor of alpha-glucosidase, which is an enzyme that releases glucose from carbohydrates in the small intestine. Diabetics are advised to decrease the amount of simple carbohydrates they consume in their meals, to take in complex carbohydrates instead, to decrease the rate of delivery of glucose to the intestines. The alpha-glucosidase inhibitors also delay carbohydrate digestion and absorption, resulting in smaller rise in glucose after a meal. This will mean that there is less need for insulin and a greater chance that the glucose will be used for bodily functions. So the example drug given here is used for mild to moderate fasting hyperglycemia in patients with significant hyperglycemia after a meal. Drug is taken at the beginning of a meal. And the advantage of these drugs are that they do not produce hypoglycemia or significant weight gain. They are used at any stage of the disease and are effective in all patients regardless of age, genetic factors, or body weight. The side effects, however, are flatulence and bloating as a result of carbohydrates remaining in the GI system for longer times, with the gut flora producing more gas. The other drugs in this third group that alter nutrient uptake are lipase inhibitors such as orlistat. This drug is used to help decrease caloric intake from fats and therefore acts as an aid to weight control in patients with type 2 diabetes. The drug is a lipophilic compound and it binds to lipases released from the pancreas and the gut. Orlistat inhibits the enzyme hydrolysis from dietary fats in the stomach and small intestine. As undigested fat is not absorbed from calories, from energy-rich food components, are not taken into the body, and fat is excreted in the stool. The primary side effects are therefore GI side effects with, for example, fatty stools and GI discomfort. Another concern is in the use of these compounds and these drugs is the reduced absorption of fat-soluble vitamins. So, in summary, today we have addressed the role of one type of receptor tyrosine kinases, the ERBB receptors, within the context of cancer therapy. Several different classes of clinically important drugs interact with ERBB receptors. Then we moved on to discuss diabetes, two major types of diabetes, type 1 and type 2, which have different mechanisms of disease. Insulin is one treatment for diabetes, and then we discussed different types of insulin and different treatment time courses and treatment options. Lastly, we addressed the clinically important anti-hyperglycemic drugs along with their mechanism of action. Thank you for joining me for today's lecture on the pharmacology of receptor tyrosine kinases and insulin.